Yo creo que se ha mejorado en muchos aspectos.
Okay, good afternoon and welcome to this ECCB workshop on sex and gender dimension in biomedical research, organized by the BioInfo for Women initiative of the Life Sciences Department of the Barcelona Supercomputing Center. My name is Davide Cirillo. I am the head of the Machine Learning for Biomedical Research Unit at the Barcelona Supercomputing Center. So first of all, I would like to thank the ECCB organizers for giving us this space to discuss with you about our work and this very important topic, and for all the support throughout the organization of this event. The BioInfo for Women is going to be present at the main conference as well. So in particular, I recommend you not to miss the poster session, where several researchers of BioInfo for Women will present their work and the activities of the program. So the agenda of the workshop is at the ECCB webpage, so you can check it there. The identifier of the workshop is NTB-W07. And okay, so the workshop in terms of structure is going to consist of 3 phases, and each one of those phases is followed by a Q&A session. So please use the platform for the live chat to post your question, and we will read the question to the speaker after their presentation. So in the first phase, we are honored to have Professor Sabine Ortlet-Prigione giving a keynote on this topic. Then in the second phase, Dr. Natalia Buslon and Atia Cortez and I are going to talk about the work of BioInfo for Women in this area. And in the first phase, Fatemeh Baghdadi is going to guide you through a hands-on session on bias detection. So without further ado, let's start by introducing our keynote speaker. So Professor Sabine Ortlet-Prigione is Professor of Gender in Primary and Transmural Care at Radboud University and Professor of Sex and Gender Sensitive Medicine at Bielefeld University. So Sabine, thank you so much for being here. We are really looking forward to your presentation.
Well, thank you very much for the invitation and the opportunity to be here today. I'm very much looking forward to the workshop and also to hearing what you are going to tell us about. I'm going to share my screen with you. And there you go. You first see yourselves. And now you should see my presentation. Could I have just a brief confirmation? Are you seeing it? Is that okay?
Yes.
Okay, perfect. Well, yeah, I'm going to talk a little bit about the impact of sex and gender on biomedical research in the widest sense, hoping to give us some generic, I would say, tools for our discussions afterwards, and in trying to shed some light about what it is that we try to do in this field. Now, here. What I will talk about is, well, first of all, why should we look at the gender dimension in general? So the gender dimension is the terminology that the EU Commission uses to define all sex and gender related research. So why does that make sense at all? Or why should we incorporate that in our work? Then I will talk about the operationalization of sex in biomedicine. What is it that we're measuring or trying to measure, or sometimes measuring without knowing what it is exactly that we're doing? And giving a bit of methodological clarity, which is so important when you do work with big data sets. Then I will talk a bit about gender in biomedicine, which is more novel, I would say, as approach, while we are starting to develop quantitative methodology to measure gender. I will give you a few examples of what can possibly go wrong if you don't do it. So trying to convince you to apply that to your work. And then I'll say a few words about the connection between content and context. Well, why do we need to do this kind of work at all? So what's the scientific rationale behind it? And different funding agencies that are all asking you to look at sex and gender in research right now have different motivations, but at the end of the day, they boil down to a few quite relevant concepts in the field of research overall. So the European Commission, under the umbrella of Horizon Europe, will tell you that if you look at sex and gender in your work, you will improve the scientific quality and societal relevance of the work that you're doing, the type of knowledge you're producing, technology or innovation you're developing. The Canadian Institutes of Health Research will tell you that looking at sex and gender increases the rigor, reproducibility, and generalizability of the science that you're producing, and it is really an excellence criterion. And the NIH in the United States will tell you that it enhances reproducibility through rigor and transparency. So overall, if we look at what these funding agencies are hoping to achieve by asking you to look at sex and gender are not small aspects. It is really about the reproducibility of science by making it more robust and rigorous. It is about producing excellent results and is about the societal value. It's really about trying to produce data that is of value to the largest possible fraction of the population and not just to particular selected groups. The way we are expected to do it then is slightly different in different countries. And interestingly enough, this is the approach that we have been using since Horizon 2020, which was the previous research framework program, and which is moved into Horizon Europe, which is the framework program that we have now from 21 to 27. And what it does is it really divides the whole approach into 3 layers. And one is looking at gender balance in research teams, one is looking at gender balance in decision making, and one is looking at the integration of sex and gender analysis in research and innovation. So if we separated this, what the EU wants you to do is really to look at 2 layers. So one is a contextual layer. So who actually gets to do research? And so depending on who gets to do research, which questions are being asked and which decisions are being made. And then there's the content part, which is what I'm going to talk about today. And we don't have enough time to talk about both of these. So we'll talk about the content part mostly, which is the operationalization and the methodologies we're using to measure sex and gender in research and innovation. Now, if we focus on that, I think the first step we need to take is to try to get our terminology right. So in the past, sex and gender have been conflated quite frequently, and this still happens sometimes. But overall, in the last few years, I'd say in the last decade, it's become a lot clearer what it is that we are investigating, really. Sorry, this just shifted. Now, when we look at biological differences and really the core of what sex differences are, this is what we start with. So we look at genetics, at hormones, at anatomy, and at physiology. But then around the role of sex that we could be investigating, there's gender. And gender is best measured in biomedicine by dividing it into different dimensions. So gender is actually a concept coming from the social sciences, which had been investigated and theoreticized mostly with social scientific methodology, so a little bit different than what it is that we usually do in medicine. So we had to start coming up with ways to measure this in a way that is adaptable to biomedicine. And again, what we try to do now is divide it into different dimensions: identities, roles, relationships, and institutional gender. And I will come back to that as we move through the gender part. Now, let's start, though, with the biological sex differences. So this is a slogan that the Canadian Institutes of Health use: is every cell has a sex and every person has a gender. So I'm only using the first part because we're talking about sex here. And this is just to say that really sex differences or sex correlates are something that we all have and that influence the way we live as human beings, the way we experience disease, and the way we experience management and therapies. The way we usually define sex, or we can measure sex, is 3 layers. So genetics, gonads, and genitalia, and this is where the 3 Gs comes from. What does that mean? So the most simple, in quotation marks, way to measure sex is by looking at genetics. So we have 2 sex chromosomes, the X chromosome and the Y chromosome, and most of us have 2 of those, either XX or XY. So we can assume, looking at the statistics, that about 49% of the population will have an XX correlate and about 49% of the population will have an XY correlate. And why am I saying 49%? Because there's a small group in the general population, which, however, if you look at big numbers, is not that small, who has also variations of these chromosomal numbers. So some people have X0, only one X chromosome. Some people have multiple copies of the X chromosome. But more importantly, and this applies also to people who have had a correlate of XX or XY for most of their lives, as we age, it might happen that some of our cells lose one of the sex chromosomes, especially the cells that are rapidly dividing. So if we look, for example, at blood cells in aging individuals, so over the age of 60 or 65, we will find that a certain number of peripheral blood cells circulating in our blood actually are monosamous. So this monosomy applies to mostly the X, so you can have cells with one X chromosome. One Y chromosome is rare because the cells usually don't survive that long, but monosomy of the X chromosome is not a completely rare phenomenon and has been investigated already in the field of autoimmunity and possibly cancer. So what that means is that, first of all, even if we look at genetics is not as easy and always binary, but also that in the course of our lives, our cells might change. And so even if most of our cells are XX or XY, it might well be that some circulating or rapidly dividing cells are not anymore as we age. And it's something we might have to take into consideration in our work. The second layer is the gonads, which means the hormones. The second way to measure sex is by looking at hormones. So we have many different options here, considering the fact that most human beings produce all hormones. It's just that we produce them in different concentrations. And that also affects what it is that we can be measuring. We have options to measure the most bioactive if we want to measure estradiol or estriol, so the female sex hormones. We would wonder men produce them as well, just in lower concentrations. So here we can measure either the most bioactive or the most abundant ones, for example. Then we can measure testosterone or its predecessors. We can measure sex hormone binding globulins, which are proteins that actually bind these sex hormones. And when we make these decisions, we have to be quite careful of when it is that we are measuring, because hormones change throughout the day, throughout the month, and throughout our lives. So when you measure testosterone concentrations in the morning, they're quite different than the testosterone concentrations you will measure in the evening. If you measure estradiol or a progesterone, they will be quite different in the course of a month of a person who is menstruating. Or if you look at all our hormones, they will be quite different when you look at what the profiles are when we're 30 years old or when we're 70 years old. And this is not just important if you investigate sex-related diseases, so something in the field of urology or gynecology, but it is also quite important, for example, if you investigate things that at first sight might have nothing to do with these sex hormones. For example, immunology or T cells. So this is an example of how the concentration of hormones during the menstrual cycle affect the T cell response. So when, for example, you're studying the response of T cells to an infection or to an autoimmune disease and how they behave throughout the months, depending on when these cells have been harvested, so for example, in the follicular phase or the luteal phase, they will behave differently. And the profile will be more Th1 oriented or more Th2 oriented. So even cells that at first sight might not be correlated with anything sex related might actually be quite affected by this. The third option is genitalia. And I would say this is probably how most of us have been assigned to sex, to one sex or the other upon birth. I say this because when we measure sex, most of the time, this is the information we have. Because I would say that most of us don't really know what our karyotype is. And most of us definitely don't know our current state of hormones. So in most cases, sex is defined by this. However, if we look only at anatomy to define sex, we'll see that a certain degree of people in the population do not fit in this. So it might well be that either they have genitals that could not be assigned at birth, or they have genitals that might not match their internal genitals. So they might have, for example, have a clitoris and still have internal testicles. So you might have different combinations there. This can be due to all kinds of differences in the development of the hormonal pathways. The degree of the population affected by this is quite different depending on which statistics you look into. You see that we have from 0.07 up to almost 2%, depending which kind of classification is being used. What I'm showing you here is a mole, and I'm showing you the mole because the mole is quite interesting in that respect, because it's a mammal, so it's not that far away from us. So it's not like a fish changing sex, and this seems like not so surprising. The fact with the mole is that the mole is intersex. Female moles are intersex by nature. So what that means is that all female moles, which are fertile, have testicular tissue in their womb. So they have functional testicular tissue in their womb, which produces testosterone. And this testosterone makes their muscles in their arms grow so that they're strong enough to live under the soil. So in a way, their being intersex by nature, naturally in a mammal, is actually a biological advantage to adapt to their environment. So intersex mammals are actually not surprised. There are quite a few. Why is looking at sex important, and why can it affect the work we're doing? So for example, when you work with cell cultures, sex can have quite a few impacts. So I talked about the stability of the karyotypes before, about potentially losing an X chromosome or a Y chromosome as you get older. And we know that in the field of oncology, this has been described quite well. So when you have cells in culture for a long time, and this applies to a lot of cell cultures being used in the field of oncology, they tend to change their karyotype over time. So you might have multiple copies of the autosomes, and you might have potentially multiple copies of the sex chromosomes. You might also lose some of these copies. So that means that your cells might have a different karyotype than what you're thinking about. If you use techniques like reprogramming and building organoids, the inactivation and reactivation also changes the potential methylation of the X chromosome. So basically, you are going a step back in the development of the cell, and then you're going a step forward, and this might change the methylation profiles. Of course, also the media you're using might have an impact. We don't know exactly in how far. We know that some media might accelerate growth in some cells more than others. And we also know that if we, for example, work with hormones, different hormones, whether they're purified or synthetic, might have different impacts on the media we're working with. So there's a lot of different effects we can take into consideration. And this is an example if you're working with animals, for example, so not with cells, but with animals, in how to proceed to actually try to find out which kind of effect do the hormones really have. So let's say you work with mice and you find a difference between female and male mice. So the next question you'll be asking is, for example, as I said, you can measure different hormones. For example, your question is it correlated to ovarian E2? So to find that out, you will have to do different experiments. And what you're probably going to do is you will have 3 groups. In one group, you will do a sham operation. So you'll do the operation, but you really don't take out anything. In the second group, you will take out the ovaries of these mice and give them a vehicle, which is basically water. And then in the third group, you will take out the ovaries, but replace the lost hormone, the lost E2. And what you're going to look at is what happens. So if you take out the ovaries, this will probably abolish the difference if the connection is to E2. And if you supplement the E2, you should restore these differences. So then you can look at these and see what it is, which pathway is relevant here. So if we confirm that the ovaries play a role in this case, then we will have to ask the question, which estrogen receptor is it really? Estrogen has several receptors. It has an alpha receptor, a beta receptor, and a G protein coupled receptor. So there are knockout mice for all of these different estrogen receptors, and you can try to figure out which one it is that actually promotes the phenotype you're seeing. And after that, the last step you will have to conduct is that actually happening in all tissues of the mouse's body, or is that only relegated to some of them? So it's quite a lengthy process if you want to do this properly, and I would refer to this review, which details quite well on how to go about that. So if we look at animals, it's not just about the gonads again. There's a lot of other factors that also play a role, which have been described quite well in the last years. What we feed our animals, for example, plays a role. So if you give them a soy-based diet, it has estrogen mimetics into it. How many animals do you put in a cage? Do they fight? Do they get along? What are the social dynamics? In how far does room temperature or lighting affect the way the animals feel? So there's a lot of factors to take into account. And again, I put a reference here for you if you would like to go into the details. Now let's move over to gender. So, and if the investigation of sex is not as simple as it looks, the investigation of gender is even more complex. I put the figure here again that I showed you before just to pick up these dimensions I would like to dive a little bit more into. So the first one is identity. Gender identity is really who you are. Are you a woman? Are you a man? Are you a non-binary person? Are you agender? So this is really something that only the person you're talking to really knows, and is something I have to tell my students in medicine is if you want to know, you need to ask. This is definitely the subject that we mostly find in the media, although it's only a fraction of what gender is made up. Because when it comes to behaviors and to health behaviors, especially, probably the other dimensions of gender might even be much more important than identity. The second layer you could be looking into is gender roles. So gender roles is what society expects you to act like if you're feminine or masculine, and or none of the two, or androgynous, and especially what happens if you don't conform to these roles. So what are you expected to behave as a feminine person in Barcelona in the year 2022? Or what would that be like if we ask the same question in China, in rural area in the year 2022? It might be quite different. And what happens if you don't match those expectations? The third layer is relationships, which is really the interaction between two people or multiple people in private or public contexts under the umbrella of gender relations. So in how far does gender affect how we interact with each other? And then there's the institutional layer, which we shouldn't forget, and is how our organizations and how our laws are actually influenced by gender, maybe in invisible ways, but that still affect our opportunities. If you want to investigate that, you have several opportunities. I'm only going to show you a few highlights here to give you a glimpse of what that could look like. So if you want to investigate gender identity, the most common way to do this is the two-step approach. And what you can do is you can ask participants in your study, if you're collecting data, especially if you're collecting large masses of data, what sex they were assigned at birth. So female, male, intersex, potentially something not listed here if they like to point that out. And what is your current gender identity? And here again, if you want to do this, it would be important to test that first with the community you're addressing to find out which kind of vocabulary and which kind of definitions work. But this way, you will gather information on sex and gender. The second layer is when you want to look at gender roles, there's different opportunities as well. What I'm showing you here is the BAM sex role inventory, which is not the perfect way to measure gender roles, but it is still the ones that is most widely used in medicine today. And so in this case, it's interesting for you to know that, just to have an example of what that looks like. So the BAM sex role inventory has been developed in the 70s in Berkeley. And what it does is it kind of tries to define stereotypical femininity and masculinity, and androgeneity, which is basically people that conform to masculinity and femininity. And then it has been used in association with many, many different diseases and many different health-related questions all over the world, although we also have a lot of criticism to it. But I think we could pick that up maybe in the discussion. The third layer, which is gender relations, and I mentioned initially, can be measured in the private and public space. So most of the research here is done in the private space, especially asking couples, for example, how they negotiate different duties, different care duties and work duties. Interestingly enough, if you want to measure that, I would recommend that you measure it at least in two ways. So one is you can ask couples, in this case, these were heterosexual couples in Sweden, you can ask them how equitable their partnership is, and this is the self-perceived here, the brown bars. But then I would urge you to also measure it in some other way, where you, for example, what they did here is they measured how many hours people do work, how many hours do they spend in unpaid work, who takes care of the children when they're sick, who takes care of relatives, and so forth. And then when you quantify that, you will see that there's quite a difference between the self-perceived and the self-reported index. So if you want to measure that, consider that there's a social desirability bias that might be more or less strong. And so it's important to do that in different ways. There are some approaches in trying to bring together different dimensions in one index. This has been Luis Pilota's one, developed in 2015 in Canada. There have been quite a few developed after that. the tentative way here was to bring together different dimensions. And you see, for example, here the BAM sexual inventory, and you see questions, for example, of household labor division. What this score does specifically is it gives you a probability between 0 and 100% to be a woman. So it spits out, let's say, an 80% or a 20%. Which might work quite well for research purposes. For clinical purposes, the question will then be, okay, what do I do with that? Which is also one of the questions or criticisms that have been made to this kind of index, and which also prompted other people to look further and try to develop these further. But it's definitely a first step in a direction to operationalize gender. Of course, it's not that easy, and this is just a nice summary showing you how sex and gender are, well, we try to take them apart in the research we do, but the reality is that they do intersect. So this review by Lori Heiss that I would recommend if you are interested, published in the Lancet in the gender edition in 2019, shows you that we're all born with sex correlates. And here again, you have the genes, the genitalia, and the gonads that I mentioned before. But then as a baby, we grow up in a world, and the world around us, our family, our community, our institutions, and our policy in the countries where we're living are permeated by gender norms. So these gender norms will be applied to us while we grow up, and we grow up in a gendered system. And these gendered systems, together with many other factors, many other intersecting dimensions, such as ability, age, class, and race, generate certain hierarchies in our societies. And these hierarchies can lead to inequalities in health. So they can lead to differences in exposure to certain risk factors. They can lead to differences in access to healthcare. They can lead to all kinds of biases, explicit and implicit, in our healthcare systems, which can then affect us at the individual level, but can also affect the whole system overall. Now, after talking about what it is that we're actually measuring and trying to bring a bit more clarity to that, let's look at some of the consequences. So what can possibly go wrong if you don't do it? Now, the first step that I would like to mention is reproducibility. I showed you initially how the funding agencies think it is important to look at sex and gender to increase reproducibility. And this has been shown in 2014 for the first time by Jeff Mogul's lab in Canada. And there's just been a publication, in a large publication as well, showing that, confirming this information actually from another lab that's completely unrelated. So we're seeing more information coming out of this. And what they basically showed was that the experimenter sex, so the pheromones that we as humans produce, can affect the reaction of the mice that they were investigating. So in their specific case, they investigate pain response. So they investigated how the female or the male mice responded to pain or to painkillers. And depending on who the investigator was, the mice responded differently. So this was quite surprising and also a little bit unsettling, because realizing that there can be an interspecies reaction to pheromones, because these are mice and we are humans, and still they smell our pheromones and react, might actually potentially lead to bias. So in the future, it might be important to also consider who's doing experiments, and can that potentially also be a sort of bias? And we might have to report that, which we're not doing now, and which has all kinds of privacy-related questions as well. The second layer is potentially underestimating hormonal effects. And this is an interesting study done in the Netherlands. It's a large panel of different metabolites measured for their potential association with depression. And what you see here is there are different groups. So here you have the group of males. Here you have the group of circulating females. So these were premenopausal women, all of them, in their either follicular phase, luteal phase, or postmenopausal. You see that the spread is not that different. But then you have another group here, which, if they hadn't thought about it and if they hadn't asked about it, they would have never known how to identify. And this is the group of individuals on oral contraception, which is here disaggregated completely, and it's basically a different cloud compared to the other two. However, if we didn't ask about this, we would have never known, and this would have been an undefined cloud that just behaved differently than the others. The third layer, and this is probably the most well-known one, and probably the one that is most important in terms of diagnostics when it comes to our patients is the fact that if one disease is associated with it's either characterized as a feminine or as a women typical disease or as a men typical disease in our textbooks, the other people that don't conform to that might experience delay, whoever they are. So, for example, when it comes to bladder cancer in women, we know that there is a notorious delay in the diagnosis because if women go to the doctor complaining about blood in their urine, the first thing we think about is that they might have a urinary tract infection, which is also logical because it is more likely epidemiologically. However, if you don't respond to the first or second course of antibiotics, it might be worthwhile to look further because there could be potentially other origins. When it comes to diseases like asthma, we do see a bimodal distribution. So what we're seeing is that the typical wheezing we look for and we ask our little patients for is much more common in boys, while in girls, a lot of times they only have dry cough at night. When it comes to diseases that are seen as typically women diseases, female diseases, like osteoporosis or autoimmune diseases, they are diagnosed usually later and to lower rates in men. So, for example, osteoporosis is seen as a typical disease of the postmenopausal women. So, a lot of men in their 70s, 30 to 40% of them also have osteoporosis, but most of the time we don't know because we don't systematically screen them. And then one of the more typical pictures we can describe, which affected quite some fields. This is a study from Israel, which asked patients with multiple sclerosis which kind of doctors they talked to before they got the diagnosis. So multiple sclerosis is notoriously difficult to diagnose because a lot of times you might have some symptoms and then for a long period of time you don't have anything, and then you might have symptoms again. So it's difficult because the course is not linear. So these patients tend to visit a lot of doctors before they get their final diagnosis. And what the men will tell you is that at a certain point they've been sent to an orthopedic surgeon because we thought it was some kind of functional problem. And the women will tell you that in large numbers, they've been sent to a psychiatrist, just assuming that it was a psychiatric disease, while the men were mostly not sent to a psychiatrist. And again, here the attributions we make as doctors are also important. Number 4 is if you don't look at potential sex differences, you might miss a lot in terms of effectiveness or side effects of medication. And the example here is really a historical one. So this is from the 90s. It's the Digitalis investigation group, so the DIG study. What they wanted to find out at the time was that whether digoxin was as safe as placebo. So this is actually a safety study first. They had a very large population, almost 7,000 patients and participating, which were divided half and half in the placebo and the digoxin group. And if you look at this, you would say, okay, the safety of digoxin is as safe as placebo, right? So then digoxin it's a heart medication. It's given mostly for heart insufficiency. So it was given to large groups of the population. And then it turned out that women had a lot more side effects. And some of these women, a small part fortunately, even had deadly side effects. So 5 years later, other members of the group that did the initial study went back and said, well, let's have a look at these differences we're seeing. And what they found was that this concentration of digitalis given in the initial trial actually had 2 different effects. When we look at men and the proportion alive, the men on digoxin did better than the men on placebo. However, if we look at the women on placebo or digoxin at that specific concentration, we see that the women on placebo actually did better than the women on digoxin. Now, what's the problem here? Well, first of all, it's a problem of concentration because digoxin has a relatively small range of activity before becoming toxic. And the other problem was the representation. About 25% of the participants in the study were women. So if we take a look back, we will see that those 25% were simply outnumbered by the 75% that did really well on digoxin. And so the final graph, if you don't separate it, looks like this. Now, this is historical data from 25 years ago, 30 years ago. Is that still relevant? Unfortunately, when we are under pressure and there's emergency, it seems to be still relevant. And this is data that we looked at last year during the early phases of the COVID pandemic, where we looked at trials that were registered in the large database, the clinicaltrials.gov in the United States, between January 2020 and 2021. And it turned out that only about 1 in 5 studies registered at the time wanted to look at sex and gender upon recruitment, and only about 1 every 20 studies was planning to look at sex and gender upon analysis. So these are registered studies. And then, of course, not all the registered studies will go through. They will be stopped for all kinds of reasons, and not all of them will be finalized. So we also looked at some of the published ones where the numbers are a bit better. So we looked at the 45 clinical trials that were published in 2021 in the January. And what we see is that we move, luckily, from 1 in 20 to 1 in 5. But that also means that about 80% of these studies didn't report any sex disaggregated analysis and any information about sex disaggregated side effects. My last point is you might also miss if you don't look properly for sex and gender, and this goes a bit beyond this, because what you've seen in the medical field, a lot of work is still done on sex differences with a very binary understanding of sex. But now we're trying to move a bit further and looking also at gender aspects. And as I said, you can start measuring that in quantitative terms. And we tried to do that in a first study in the field of oncology, and then we confirmed that in the field of neurology. And what we looked for were differences between men and women that were cancer survivors. So we used a quite large cohort of long-term cancer survivors. So these are more than 5,000 people which had cancer, were treated for cancer, either surgically or with chemotherapy or with radiotherapy or combinations thereof, and survived for at least 5 years. So these people are, in theory, medically cured. They are free of the tumor, but a lot of them still have symptoms, even years after the therapies. So we looked at them, and we looked at, first of all, the more biological differences, the differences in symptomatology. And what we found was quite predictable, that the female patients had more nausea, pain, insomnia. In general, they had more symptoms. Although there were 2, dyspnea and depression, that were more common in the male patients. But then, and this was quite an interesting next step, we looked at the functional domains. So this questionnaire that was administered to the patients asked about symptoms, but it also asked about functional domains, so things that go beyond physical symptoms. And these domains are the physical domain, the role functioning domain, the social domain, cognitive and emotional, trying to capture patients' experiences in a more holistic way. So what we did compared to previous studies, instead of just comparing the female and the male patients, where we almost always find that the female patients do worse, we actually used the general population as a reference, and then we compared. Why is that important? Because in the general population, we also see that women and female patients in general do worse as they age. So it is something that is connected with the aging process. What does that mean? If you adjust for the general population, what we found was this, that when it came to role functioning and social functioning, and if you think back to what I told you about gender and which kind of domains make up gender, these losses are much higher in the male patients compared to the female patients. And the female patients, the role loss is minimal, and also the social loss, while in the male patient it's quite big. So we think that this is not a biological differences, it's a gender differences, which affects probably the role and relations domain. So we went a step further and looked at that in the field of neurology. We could actually confirm that, but just to say that even with traditional scales that we're using to measure some constructs in large cohorts, we might get a glimpse at the role of gender in health, and we could explore much further on that. So my last step before I conclude, what can you do? What can you take home, and what can you do in the future to try to mitigate some of these this lack of information? Well, first of all, you should know as much as possible about your samples. As I told you before, karyotypes of samples in culture might change. Cells might lose their X chromosome, they might lose their Y chromosome. So try to figure out what your samples actually are. The second point is include at least both sexes and think about the conceptualization of gender. So if you want to measure gender, think about what it is that you actually want to measure. Do you want to measure identity? Do you want to measure roles? Do you want to measure relations? How do you want to measure that? And which of these steps is potentially relevant to whatever it is that you want to find out? I would suggest you consult an expert. There's a lot of people out there. So I'm talking to you today, but there's not just me. There's quite a few people accumulating the knowledge by now, and consult them. It's not as easy as it seems, but if it's done properly, it will offer a lot of interesting data. Then it should be mandatory to disaggregate data so that even if in your study you cannot do large analysis because your pool is too small, this data can then be analyzed by other people if you aggregate it. You should stratify your analysis by sex and ideally gender if you're measuring it. And then please don't just stratify it, but report this data. I'm saying very simple things here, but I'm really saying them because, as I said before, we simply don't find them in a lot of these studies. So it needs to be done. And then, of course, what I told you today is not proprietary information. Please feel free to share that with your colleagues and try to get them in on that as well. And with that, I would like to thank you very much for your attention, and I'm looking forward to any potential questions.
Thank you so much, Sabine, for this. It has been really great. I would like to invite the people that are connected to write the question in the live Q&A chat. So that we can read the question to the speaker. So if you want to ask something to Sabine about the presentation about this, please write down in the live Q&A. So I will Atja has a question, so I will just pass the mic to her. Atja, please go ahead.
Yeah, hello. Hi, Sabine. Thank you for this inspiring talk. So I have a question. I have to say my background is on computer science, so no medical research. But at the beginning, you were talking about, so this, let's say when we're talking about female and all the genetic information that they had, it depends also, it's not having into account the sex and the gender, but you talk about taking into account the age, right? So it depends on the moment of their lives, even if they are younger or elder, but also depending on the hormonal cycle, this information may affect potential results. So when I'm thinking about applying, for example, unsupervised learning techniques, trying to clusterize or profiling these people. So what are the challenges here? Especially because sometimes there is few information. So how can we connect all this information? Which are the challenges that we might find when we are doing this kind of research? Thank you.
Am I on mute or is my mic on? Is my mic on? Yeah.
No, we can hear you.
Okay, I wasn't sure. All right. Well, I think there's a lot of challenges. But what I did today was to try to point out that it's not as simple. So I think that is the first step. I think it's important that we look at potential sex differences, but we're also mindful of what it is that we are doing. And I think that's a relevant step to keep in mind. And I think what is important is to look at which kind of information is relevant to the kind of study you're doing. So you most likely, in most cohorts, you will have very little information. So my role here is also to be a bit of an evangelist and tell people, well, if you want to do this properly, you might need a lot more information. You need to collect it. So you can start with a certain degree, but there's a lot of caveats and limitations to keep in mind. It's not as simple as it seems. And I think especially right now in times where people like simple answers, especially in the field of sex and gender sensitive medicine, it's not as simple as it seems. So I think the challenge here is really where to find the balance between the necessary data we need to give good information and, of course, data ethics. So what it is that we can be collecting systematically from people. What that means is there are certain studies where probably it is enough, at least in the first round, to go with the information about biological sex that you have in the sample, which most likely is an anatomical information. However, if there are specific questions where hormones can play a role, where genetics can play a role, it might be worthwhile trying to get that information in an additional step. Simply because, as I said, these variations might also change what you find. So probably if there's big differences, you will still see them. If you need more nuance, and especially if you need to point out potential topics for therapy or potential topics for an intervention, then it might be necessary to gather this additional information. So in a way, what I'm saying is there's a first step that we can take, but we need to be mindful of the fact that potentially we need more information to go deeper into that and really disentangle where these differences lie.
Thank you.
Okay, so there are a couple of questions in the live chat. So one is from Janet Kokoshar, saying, I imagine, well, maybe Sabina, you can read as well following like in the chat. So I imagine that not stratifying by sex and gender is probably more convenient because powering,
Is that?
Because powering the study of gender or sex require many more samples, resulting in more time and resources. What are your thoughts about this? So it's basically like, the power, not the statistical power that you can have when you.
First of all, we don't need to double the samples. So that's the good thing is, if you do some factorial design, you might have to increase them by 25%, but not, or 50 maybe, but not 100%. So that's reassuring. But I think the point here is the reasoning of why we can do it or not. So a lot of times the reasoning is, well, we don't want to increase the sample size that much. It costs more money and so forth. But the problem is, I look at this from the consequences. And if we see that then we have pharmaceuticals that have to be pulled from the market afterwards because we find differences in effectiveness and potential side effects, they don't always have to be deadly. They can just be very impactful. I mean, let's think about Vioxx, for example. It was a disaster. They spent billions in the development, and then you risk something like this, and you have to pull a drug from the market. So I think in terms of let's think about the bigger systems rather than the immediate thing. If you miss a potential sex difference early on in the process and you proceed, it might cost a lot more later. So what the suggestion we usually make is try to look at this also in the smaller samples in the beginning. If you do not find any differences, this might justify not studying them later on, but just assume that potentially they could be there and try to investigate it at least in the beginning, because the costs, if you get to the end of the process and you have to backtrack, will be enormously higher than having had to spend some more additional money and time on the sampling in the beginning.
I have a question related to this, and this is about the experimental protocols that are used nowadays. For instance, thinking about cancer research in which mice are used, and a lot of experiments. Well, depending on the experiment, but most of the time, female mice are used because essentially they need to randomize the mice in the cages, and if they cannot do that with male mice because there is a kind of a behavioral hierarchy. And so like this randomization, which is important for getting the significance of the results, like cannot be done because of this natural structure of the behavior of the animal. So this led me think that maybe this experimental program needs to be completely thought again, like in a way. So maybe this is a space for new protocols. So this is what I'm trying to say.
First of all, it depends on the field. I worked in immunology where female mice tend to be used more, but like in the field of cardiovascular medicine, they use more male mice. So it really depends on the field. And the other thing is what people forget is that when you breed the puppies, they don't come out whichever sex you want. You have both anyway. So in a way, you have female and male that you're breeding anyway, regardless of what you do. It's Mendelian randomization. So in a way, you do have both, and they get euthanized anyway if you only want the male mice or you only want the female mice. So in a way, also from just a practical perspective and an ethical perspective, you're already breeding these animals anyway. So that's also something to keep in mind.
Right. So there is a question from Alberto Gil Jimenez. He is asking, how could we deal with biases while reporting sex and gender info in questionnaires that are then used for research? For instance, cisgender people might feel more comfortable sharing the sex assigned at birth, but for transgender, they might not feel comfortable and report it. I don't feel comfortable sharing sex assigned at birth. So is it a common issue? Are there any ways to tackle this? So, the willingness to report the sex at birth.
Actually, if you ask specifically about sex assigned at birth, that's already something that signals that you're probably looking at this in a much more open-minded and critical way. And most likely, if you ask about sex assigned at birth, you will also ask about gender identity. So that is just to say that in most questionnaires still to date, we just ask about sex, or sometimes they ask about gender and says female, male. So this distinction is really not incorporated systematically yet. However, there's a growing number of surveys where we will gain information also at the European level, in the US, in Canada, and also in some national surveys in the EU, where we will get information about sex assigned at birth and gender identity. And quite frankly, we are also working on some of these methodologies, and the feedback we're getting is actually quite positive. Especially trans individuals tell you that, oh, I feel that there's much more attention here, and I'm actually perfectly fine in answering this because I see that there has been some thought put into this. So in a way, I think you risk losing much more information with the other format. And most importantly, also because it is confusing. If it only, let's say you're a trans woman, and the question is, what is your gender? And it says female, male. And then the question is, well, maybe you transitioned at a certain point of your life. So what are they asking about? Even if you want to answer gender, when you were a kid, now, do they actually want to know about sex, but they're not asking about it? So the thing is, not having this clarity of what it is that we're actually asking about is not helpful, because at the end, it is confusing to people. So in a way, this additional step is just adding some more clarity to what it is that we're actually measuring. And this is also why some of the large statutory surveys are picking it up.
Yeah, right. So a question by Alba Genet. She says, it seems like awareness of sex and gender differences needs to happen early on in the scientific career. Would you know to which degree such awareness is integrated into medical schools in Europe and elsewhere?
It's a patchwork. I would put it like this. What we can say from our experiences is it's still very much connected to having a person there who pushes this in the local medical school or research organization. So there is no systematic integration, even in countries like Italy, which now have it in law. That doesn't mean that in all Italian universities we will hear about this. So in a way, it is still connected to individuals doing this, which means there are a few, it's very few, medical schools in Europe that do it systematically. There's 2 in all of Germany. There's 2, actually a third that kind of does it in Austria. There's a few in the Netherlands, but we do it depending on different levels. So I don't know which exact number to give you. There are, and then it depends also how. So is what you mean by integration, is it integrated in the mandatory curriculum? Is it presented as some kind of elective that people can participate in? Is it mentioned in, I don't know, grand round series and so forth? So also the degree of implementation is quite different. So overall, it is still relatively little. Also in the United States, Stanford does it a bit, but they also would like to do a lot more. Harvard is trying to pick it up a bit. There have been several initiatives. The NIH has a working group on that, but still we don't have a systematic implementation anywhere, I would say. And what we're still seeing is that it is connected to individuals or institutes or research groups in the setting that do it. And that's also the sad part, is that a lot of times when then the research group moves or the person retires, this knowledge kind of leaves with that person. So we are seeing a lot more attention. I expect, especially because students are asking about it a lot more, I expect this to become much more of a subject, because there is really a bottom-up request for it, but we don't have systematic implementation yet anywhere in the world.
And can I send something, Davide? Thank you for this talk. It was very interesting. No, related to that, Alba asked how difficult it is for researcher and also for people that work in bioinformatic area that maybe doesn't have integrated the knowledge about a medical aspect to apply later, because the European Commission, as you say, the agents ask as a mandatory to introduce this sex and gender perspective. But sometimes the educative school, the university, haven't got this. So, what is your opinion? Because sometimes, as you say, there are many people that ask how we can do that, but they haven't got the tools, no?
No, definitely. And I think the way I like bottom-up processes. So in a way, I'm all for it. And what I'm seeing is that really in a lot of research organizations and medical faculties, the request comes from the PhD students or the medical students or whoever the students are, because they feel it's an important topic. And the good thing is that usually the organizations then try to pick it up somehow. So that's why I give a lot of workshops like we're doing today. But of course, it's a one-on time, and this doesn't confer systematic implementation yet, and this is definitely what we will have to work on further. However, I also think that it is at least a first step, because most of these students get information that they haven't had before. They take it back into their labs, and it's already happened a few times that maybe the lab then picks up this kind of information, that it becomes interesting, that they look at their projects, they start looking at sex differences, they find something interesting, which becomes interesting to the PI as well, and so forth. So it is also, if you want, a bit of a kind of grassroots movement in here, but I would say it is still quite complex to get good training about this. I mean, the European Commission offers resources. There's a gendered innovation website. There's several training courses that you can access online from all kinds of locations. So there is a bit of information there. And the other layer is, we also still need to train a lot of our reviewers because some of them are informed, others not. I mean, I sometimes get feedback from reviewers telling me, you're mixing up sex and gender. And I then think, well, you didn't really read what I just wrote, because probably I know more than you do, and you didn't understand what I just wrote. So when I get back, the authors mixed up sex and gender, after explaining exactly what it is that we're doing and why one thing was sex and one thing was gender, I also wonder, on the one hand side, I'm like, okay, people are starting to get it, but there's still a lot of work to be done.
Yeah, thank you.
So yeah, thank you, Sabine. Especially like this last question somehow answer as well. This last answer, like, is for a question posted by Sivarayan about guidelines created by founding agencies. So, of course, we recommend to have a look at gender innovation. You will find all the information there. But it's also important that those, like, I mean, the funding agency, okay, but it's not just that. Also, because sometimes, like, it's just a requirement of inclusion of this sex and gender dimension in projects, and it's very mysterious, a bit esoteric way of, but actually the way in which we should tackle this is much more precise and much more quantitative and methodologically sound than just a couple of lines in a proposal just to fill up those requirements. So thank you so much, Sabine, for the talk. So we need to move on to this second phase of the workshop. So now basically we are going to delve more into the activities and the achievement of BioInfo for Women program in several areas concerned with sex and gender dimension in biomedical research. So we will have presentations from Dr. Nathalie Bouzelon. She's a researcher in sociology, and she's the diversity and inclusion officer of the Human Resources Group at the Barcelona Supercomputing Center. The presentation will be followed by one from myself. I am Davide Cirillo from the Barcelona Supercomputing Center. I am head of the machine learning unit in the department. And then followed by a presentation of Dr. Atia Cortés. She's a recognized researcher working at the social link analytics unit of the Life Sciences Department of the Barcelona Supercomputing Center. So I would like to invite Natalie to share the screen so we can start this track about bioinfo for women.
Okay. Yes. Can you see the screen right now?
Yes.
Yes, perfect. Well, thank you so much. Well, as David explained, this course, we in the Barcelona Supercomputing Center, we have the interest to develop all the knowledge regarding how to introduce the sex and gender perspective in the different area that we have. Of course, the bioinfo for women is focused in the life science department, but in the PhD program that we have in the BSc, that is for the earth science, life science, and computer science, we try to explain, as Sabine obviously explain in detail in a really good way, the consequence that have when we are working in research, in science, in different fields, okay? So we need to take into account the socioeconomic and ethical aspects of our research and how we developed AI. That is the particular focus in the Barcelona Supercomputing Center, and the consequence, the social impact that we have. So what we know in many, right now in our society, the algorithms determine a lot of areas and have a lot of impact in different sectors, as production, government, environment, education, and of course, as today we explain in health. No, so when we are researching, we need to think about that. How the system that we are develop need to be transparent, trustworthy, and have a user control, and be participative, and take into account many variables that are social, are part of our life. So why this is important? Because it's a human right to be to participate in the scientific knowledge, in the scientific advancement, and also to have benefit of the new scientific results. No. So this is related with the social development goals. As we know, the United Nations and all the countries have as objective to follow this goal, that mean to focus our research, that is public funding in the majority of the time, to focus into reducing inequalities, to have a focus in gender equity, in health, and different areas. So the different scientific evidence show that artificial intelligence, of course, have a positive impact in this goal to achieving the sustainable development goals. But as we can see, we need to pay attention also in the negative impact that could have our develops, no, our tools that we are working and we research. That's of course we are explained in health system. So here we can see that I recommend this paper that it was published in Nature 1 year ago, and that obviously, as we can see in health, we have a very a lot of research that have developed that impact in a positive way to the society. But we need to take into account the possibility of the consequence that we can have. So this system is developed for different agents. For example, we have the technology, but we have the individuals, the culture, and the needs, the different resources, and all, of course, we have also to take into account the policy and legislations, and these interact in the society. No, so there are organizations, ethical, that organize different risk zones where we need to take, we need to pay attention, because we can affect, for example, in the way we are working in economics, as we know, in hate speech, in different algorithms bias that we develop in machine learning, in biomedical areas. And of course, we need to think that algorithms can reduce inequalities, of course, and resolve bias and to improve the benefit in society, but also algorithms can amplify inequality if we develop these tools without thinking about, for example, of course, the sex and gender difference in population. So we have different type of bias that David will explain a little more. But we in 3 groups we can organize in the social bias, as Professor Sabine explained, the sex and gender, all the culture and the socio aspect that affect in our population, and the concept that we have. The racial, the ethnicity, of course, the age, religious, and also the political and the education. So we need to take into account that all the researchers have this social bias, also a cognitive bias that are more related with our individual thoughts, and the statistic bias that are connected with the validity of all the development of our AR system. We have different cognitive bias. One, for example, that is very dangerous for our research is the confirmation bias. That means when we want to find evidence to confirm our beliefs, our thoughts, and this is strongly connected with disinformation. When we try to find evidence and news that confirm the thing that we want to think about. So the Gender Innovation Project, that is with the Stanford, the European Commission, and National Science Foundation, that Professor Sabine is part of directors of this project, have different example where the artificial intelligence can have effect and science can have a consequence if we don't introduce the sex and gender perspective. And AI can be sexist and racist, of course. So we have different samples that we can find in different areas, not just in the health field, but for example, in the facial recognition, if our data is a majority male and white male, the error will be worse in the dark female, and this is a consequence that we'll have in the population. Also, for example, if in our design of engineer we don't have the sex and gender perspective to check the crash testing. For example, in this case, the majority of the dummies that were used to is in a male norm. So the female driver will have 47% more likely to have injuries than men. So this is a problem that happens if we don't have into account the consequence and the social impact of our design and our research. So the recommendation is to take into account all these variables and also the intersectionality, because the intersectionality describes the overlapping of this type of form of discrimination related to this variable, the race, the age, the ethnicity, the sexuality, of course, and also the socioeconomic variable status and geographic location. So researchers should consider this factor and not just insulated. We need to analyze all this relationship when we are develop our project and our research. So as it was mentioned, right now the European Commission and the majority of the the issue of funding, like the National Institute of Health or other, for example, in Spain, also as mandatory to incorporate the sex and gender analysis and perspective in our research. So this is so important, not just in the data, in all the different steps in our research. When we identify the problem, we will decide, and the analysis, and of course dissemination, and who in all the different steps. Finally, it's important to, when we are developing AI different systems, to take into account all these ethical, legal, socioeconomic, and cultural aspects, because we need to have a trustworthy AI. And this means to define all these during all the system, the diversity, the not discrimination, the social environment, the accountability, of course, the transparency that we have in our code, in our algorithm, and the privacy and data and data governance of all the data we have, and the technical robustness. So we want in Bioinfo for Women to show that this is so important for all the work that we organize. And there are a European report that showed a list of a list of checklists where you with different questions you can check if your system are trustworthy, and this is connected with the fundamental rights and also with the goals that we mentioned that affecting the society, environment, and consumer. So I left to Davide that will connect all this work that we are doing in health area.
Thank you so much, Natalie. So we go on talking about sex and gender bias in AI and health. So can you confirm that you can see my screen, please? Okay, thank you. Okay, so we will talk about specifically about the role of artificial intelligence, the relationship between artificial intelligence and precision medicine. So as you know, precision medicine is looking for more targeted and specific treatments for an individual or a group, a distinct group of individuals. And those, this is based on characteristics like the demographic features like age, sex, gender, ethnicity, genetic factors like mutations, medical history like comorbidities, and also important, as Natalie was mentioning, the socioeconomic context, such as the environmental conditions in which those people live, and the psychosocial factors. So all those are determinants of health, and all those are elements, attributes that precision medicine needs to take into account. Now, as you can imagine, like by intersecting all those different characteristics, we can identify different groups of people. And so if we are developing an artificial intelligence that is, for instance, recommending a treatment or a therapy, we want this system to be as good in one group as in the others. So we don't want an artificial intelligence system that we use in the healthcare that is working very good for one of those groups and very bad for the others. So this kind of systematic errors that a technology can do, we call them biases. And in most of the cases, those errors, those biases emerges because there is a problem in the data, a problem of representation in the data. So much so that in machine learning area, we generally say that garbage in equals garbage out. So if you have like data that is not complete, or the quality of the data is not as good as an input for your artificial intelligence, you are going to have a biased result. But I don't really like this way of putting the issue, because it's really focusing only on the input data, while we should ask much more questions than the ones about the input data. I mean, for sure, it's it's important to ask, for instance, how the data that we are going to use to train an algorithm has been generated, collected, or processed. But we also need to consider other elements, like, for instance, what is the model actually learning? If there are something in the model that is creating this bias, maybe the way in which we are training it. And also, like, focusing on the output, like how will the output of those algorithms be used in the real world? Who is going to use it? Who is going to access the information, and for what? So as you can see, it's much more complex than just garbage in, garbage out, as they generally say. So it's complex because all those different biases can emerge at the different steps of the so-called life cycle of AI development, that, as you can see from this slide, is composed of different steps. So there are some biases that are specific of the data generation. We can have historical bias, representation bias, measurement bias. And then we can have other biases that are specific of the phases of model building and implementation, like, for instance, aggregation bias, evaluation bias, and deployment bias. I'm not going to explain each one of them, but just a couple of the most common ones, like, for instance, representation bias, which is essentially when you have different groups, like an overrepresented group and minority groups in your data. And the problem with representation bias is that most of the time you don't even know that you have multiple groups in your data, because, as I said before, like, maybe a group can be defined by specific characteristics, and this is not even the information that you have about those individuals. So you should really, like, put a lot of attention about this. Evaluation bias is a bias that is related to the model evaluation. So essentially, when we create an artificial intelligence model, we generally evaluate their performances by using baselines and benchmarks that are chosen in a quite arbitrary way, and then we will evaluate, like, the performances of those models based on this, and then this will let us tell if the model is a good model or is a bad model. But this is not, I mean, this is, of course, like, it's very limited as a way of evaluating those systems. So we can have an evaluation bias if we do not choose properly the benchmark that we are using for this. An example of representation bias comes from the field of genomics. So we have a lot of genome-wide association studies that have been collected throughout the years, and we are realizing right now that most of those are biased towards men of middle age and of European ancestry in particular. And because those genome-wide association studies essentially are performed on a big cohorts of people and allow you to identify variants that are associated with a specific trait. So if you, like, based on the composition of this cohort of people, which are generally very large group of people, based on their composition, also in terms of sex and gender, you can spot one variant or another one. And so, like, in this slide, you can see, like, one way of, for instance, addressing for sex differences in genome-wide association study, which means running these experiments by disaggregating the two groups. And as you can see, by doing this, you can spot variants in the genome that are actually differential between men and women. An example of deployment bias is, for instance, when you want to run an experiment using a digital device like a smartphone, without considering that in different countries you can have a different access to this technology between men and women. So on the left, you can see the probability that how less likely is a woman to own a mobile phone than a man in different geographical region. And you can see that, for instance, in Europe, the situation is quite balanced. But if you do this experiment, if you collect data from smartphone in South Asia, men are much more likely to own a mobile phone than women. So this can affect your conclusion, your results. So all those biases that I was mentioning before, like, those are just some of them, and also Natalie mentioned many others. And actually, like, a complete taxonomy of bias has been attempted many times in the literature, but it failed miserably because there are many different types of biases, which is actually natural, because there always be new biases coming out, and this is because society is always evolving, the technology is always evolving, and so new biases are coming out, and this is why it's so difficult to survey all the existing biases. Still, there are some useful categorization, for instance, like this one that has been introduced by Professor Baeza Yates from the Northeastern University. He basically classified biases into the ones that are more technical, that we can call them statistical biases, that are deviations from a prior distribution, and the ones that are more related to ourselves, so to humans, and how we judge the world. So cognitive bias, that are deviations from normal rationality and judgment of one individual, and cultural bias, which is the same but of a group of individuals. So in biomedicine, the generation of biased data is a big issue. So as I said before, especially in the field of artificial intelligence, the problem of biased data is one of the main problems, and this is even more true in the field of biomedicine. For instance, here we have a representation of the path that lead to the marketing of a new drug and its development, and basically, as we heard from the previous presentation, we can have biases at the level of the preclinical studies with animals, at the level of clinical studies with humans. For instance, if those clinical studies are run only on male, and we develop a new drug and this drug is put on the market, then it's not surprising that we can see side effects, especially in women. Now, there is an extra layer of complexity here, because each one of those steps is producing data, and if this data is biased for some reason, researchers and machine learning engineers can pick up this data and use it to train artificial intelligence system for whatever reason or for whatever task, and but of course those will be biased as well. So in order to stress even more like the importance of sex differences, even at the level of preclinical studies, so in animals, here we have an example of this. So those are the routes of how pain is conveyed in male mice and female mice, and you can see that the actual cell types that are doing this job are different in male and female. So if we are collecting data only for one sex and not the other, we are basically only looking at one side of the coin, only on one part of the biology of this animal. The situation, the way in which we should perform, we should pay attention to this problem. It has been mentioned by Sabine before. So it's basically to run our experiment, and if we see that there is no clear difference in a balanced situation, we can probably keep going with a mixed experiment. But if we see that there is a potential sex difference, we should strongly consider increasing the numbers of both sexes. And as we said before in the discussion session, I'm completely aware that this comes with a lot of expenses, and it's costly, and sometimes even the facilities in which these experiments with animals are done are not prepared for this. So it's something that it needs to be taken into consideration, but this is definitely the way in which one should go when a sex difference is identified. The situation is even more, let's say, worrying when we look at the clinical trials. So here it's about humans, and here we have an example from clinical trials that led to the approval of new molecular entities, which are kind of promising compounds that go farther down the pathway of drug development between 2015 and 2016. And as you can see, we have the representation of men and women in this plot, and in some medical areas there is a big difference. So and of course, this can lead to all the problems that we saw, that we have been talking about before. And this is also the reason why then when you look at pharmacovigilance data, or even when you look at electronic health records, like for instance in this study here that we developed at BSc with the Instituto Gulbenkian de Ciência in Portugal, you realize that there are actually striking differences in the way men and women are, for instance, dispensed drugs, and the effect that those drugs can have in the two sexes. So in this study, what we did is to calculate the probability that an individual has to be receiving drugs that are interacting between them toxically. So we analyzed the electronic health records of 3 populations: the Blumenau city in Brazil, the city of Indianapolis in the United States, and the Catalonia region here in Spain. So as you can see from there is a red curve and a blue curve. The red curve refers to women and the blue curve refers to men. And especially in Brazil and in Catalonia, the probability that a woman is co-dispensed in the pharmacy a drug that is interacting toxically with one that this person is already taken is much higher than men. So in short, women are at a higher risk than men of being prescribed drugs with a toxic interaction. This effect is stronger, as you can see, in Brazil and in Spain, and much less in the States. And this is probably due to the fact that there is a private health system. So the alternatives for drugs with less interactions and with less side effects is higher than in other regions of the world. So this is about the effects that you have eventually if you are not if you are putting on the market drugs that can have interactions that are not studied in the two sexes differentially. And this is also the reason why historically a lot of drugs have been withdrawn from the market, especially for greater health risks in women. And here you have a table with some examples. So what we can do. So if we want to like practically act on this. So if we are studying out, if we have data and we want to analyze them under the lenses of sex and gender, what we can do. So as we mentioned before, there are recommendations from Gender Innovation, and in particular those questions that you can ask your data. For instance, if you want to determine the source of sex differences in your data, you want to investigate sources like from the environment, from the genetic, from the hormonal dynamics, and so on. But also, interestingly, there are recommendations for a gender centered analysis. So imagine that you want to determine the sources of gender differences. You have to think about if they comes from gender norms, gender identity, gender relations. So all aspects that probably you are not familiar or you are not like very much used to take into consideration when you are analyzing the data, but that it's very important to take into account if you want to have this kind of insights from the data. In terms of if you want to like automatically do this, there are a lot of open source toolkits for bias detection and mitigation. For instance, this one that is maintained by the University of Chicago is called Equitas. And then this other one that is produced by IBM, this is still open source. And we are going to have a look at specifically this toolkit from IBM in the hands-on session in the next part of the workshop. So the last thing is about machine learning fairness. So machine learning fairness is basically a new branch of computer science that is focusing specifically on how to ensure that our AI models are treating all those groups fairly. And so, first of all, in order to make this operative, we need a definition of fairness. And this is very complicated because we can define fairness in many different ways. So from the point of view of a classifier, we can have again, different definition. The simplest one is called demographic parity. So this is a notion of fairness. And imagine that you have two groups. So here we have men and women. And we have a predictor that is predicting something about those two groups. It can be like a diagnosis of a disease or whatever you want. And we are like representing this predicted value with this square. So in this case, for instance, this predictor is predicting something for this group of people. So it's predicting something for 50% of the male. And so in a demographic parity scenario, we want a 50% of prediction to be delivered also for the other group. Now, this notion of fairness is saying nothing about the quality of the prediction. So if we want to take into consideration also the quality of the prediction in our fairness notion, we should use equal opportunity. So here we are ensuring that the same true positive rate that there is the same true positive rate for the two groups. And this is a requirement that we can set for our classifier. If we want to be even more strict, we want our classifier to give the same true positive rate and false positive rate for both the groups that we are considering and for which we want, fair predictions. So how can we use this? We can use this in this way. So, for instance, this is from a study in which they use fraud data. So it has nothing to do with health, but the same can be done with health data. So all those points are different artificial intelligence models belonging to different families like random forest, neural networks, and so on. The classical way of picking the best model is to looking at the predictive accuracy. So if you have to choose one model, you would probably take this one because it's the one with the highest predictive accuracy. But if you add this extra axis that is about fairness, you can see that this model here is not the one with the highest fairness. And so like by looking at fairness together with the evaluations metrics that we are generally using, like predictive accuracy, you can actually, you have like a more, you can pick like a better model also in terms of fairness, which can be something here along this Pareto front. So with this, I conclude and I pass the mic to Atia for this part about the Bioinfo for Women research line. Thank you.
I will now share mine.
Mm-hmm.
Okay. So you can see the slides now. Yes. Okay. Yeah. Okay. So in this last block of this part, I will introduce you the Bioinfo for Women program very briefly, and then I will focus on the research line that we are now starting to launch together with Davide and Natalie. So just to put you in some context, this Bioinfo for Women initiative is from the Life Science Department in the Barcelona Supercomputing Center. And one of the aims is that, okay, we've been talking now about this unbalanced data representation and how there is this bias with sex and gender, but there is this also, this happens also, this lack of representation in the workplace, and especially in STEM careers. So I'm sure that you are more than aware about this kind of numbers, but just to show you some numbers that we have here at the BSc, we can see that there is just over 1/3 of female women working at the BSc, and more or less the same representation of PhD students. And these numbers usually decrease as long as we progress in the academic or research career. So what we want to do in this program is to have some actions that will promote the visibility of women. In particular, we try to find women that are in leader positions that can inspire younger researchers. We try to promote also the visibility of these young researchers in different kind of events, build some networks of collaboration, and then try to disseminate as much as possible the research that is being performed by women in the life science department through different conferences and other kind of events. And also very important is to create these role models for young researchers, but also for even younger girls that are trying to decide which kind of future to take, okay? So we have different lines of interest. One of them is about the internationalization and the networking, participating, as I said, in different conferences. We were already in the ECCB 2020, and this year, here in ECCB 2022, we start with this workshop today. But as David said at the beginning, we will have different participations in the conference, especially with the presentation of different posters that will show some of the work that we do. But also we will have a physical booth in the conference. So don't hesitate to go, say hi, and ask about more information. We also have this line on supporting women's career, trying to promote them from young researchers to senior researchers. And we are now also starting a piloting mentoring training in which senior researchers are mentoring young researchers during 1 year and try to help them in different aspects of their daily work environment. And finally, we have this research line, which is the main interest of today. So I will show you now in more detail. We have participated in different elaboration of documents and events such as the Elixir Biohackathon. So what we do in the world, let's say, is to first organize different kind of seminars. In particular, here at the BSc, we contribute with seminars that are provided by women that will show the research that they are leading, but also conferences and mentoring, as I said, and then we are trying to build this network with other institutions and programs that work on the same field. And finally, we try to organize also different events during the year at the BSc, such as, for example, the BioInfo Women's Day, which is on February 11th. We open the doors to young researchers to see the work that people is doing in our department, and in particular, work that is being led by females. We have, as Natalie mentioned it at the beginning, this PhD training program in which we provide a course on incorporating the gender perspective in research. And in this research line, we have also elaborated different documents, and the most important is this book that I will introduce you later on sex and gender bias in health and AI. So now I will introduce you on more detail this research line. The idea is that, as you might already know, artificial intelligence is now present in our daily lives in different sectors. And in particular, it has a huge impact on the health sector and in what interests today, the biomedical research and the decision-making in clinical research. So there are many advantages. We can use different AI techniques such as big data analytics, but also data coming from digital biomarkers, using also techniques of data processing such as natural language processing and other kind of techniques to act into the environment such as robotics. And the combination of all of these provides cost efficiency, benefit, but also a dynamic access to health information and other opportunities to handle different problems in an efficient way. Also, as we have seen in the previous presentations, if not done with several considerations, artificial intelligence can enhance some biases that are already present in our society, such as the promotion of stigma and discrimination, to enhance these unrepresentative samples in data collection, or to have some adverse reactions and treatments. But if we also work well with all these techniques that we have and we incorporate new research trends such as explainability, explainable algorithms, or the fair data generation, we can also enhance desirable biases. That means to understand what are the differences in terms of sex and gender, and to elaborate effective treatments for each sex or gender, and in the end have a positive impact in the well-being of the patients. So these are the main challenges that we have here in this research line, trying to identify which are these unnoticed biases that may have a negative impact on people's health and well-being, but also trying to understand which are these differences that will be relevant in order to train our data sets and our artificial intelligence-based models, and then to achieve fair precision medicine. So we have different actions in this research line. The first one is to raise awareness. When we talk about raising awareness, we are not talking here only about the people that is doing biomedical research, but in general, in any stakeholder that is affected by AI and health, including the society. So we aim to provide a space for open debate between the scientific community and the society regarding this topic. We also want to identify different strategies to disseminate our scientific results and educate the society and have the best impact to all kind of audiences. And then, as Natalie mentioned it at the beginning, to achieve on the Sustainable Development Goals. So we have done already some actions in the last 2-3 years. One of them was to organize the Sex and Gender Bias in Artificial Intelligence and Healthcare project in collaboration with La Caixa Foundation and the Palau Macaya in 2021. So we had different conferences, seminars with roundtables with different experts, and workshops in the format of co-creation, design thinking methodologies. And with that, we did a report that is available on the internet. And it was a compilation of all the opinions and ideas that we gathered from all these experts that collaborated with us. And the good thing is that we tried to build it with a multidisciplinary background. So people coming from the biomedical research, but also from computer science, policy making, and other kind of expertise. Another important achievement was the publication in 2020 of this article, Differences and Biases of Sex and Gender Artificial Intelligence and for Biomedicine and Health. This was led by Davide Cirillo, and it's available on Nature. Here you have the reference. And here what they tried to do was to identify what I was saying at the beginning, these different undesirable and desirable biases, and how they were present in different AI technologies such as big data, robotics, or NLP. And as mentioned before, also a very important achievement was the Sex and Gender Bias in Technology and Artificial Intelligence book. This was published in Elsevier at the beginning of this year. It's a collaboration between several organizations and private companies, as you can see here, and it was mainly led by the Women's Brain Project Initiative and the Barcelona Supercomputing Center. It has 3 different sections, one more regarding the general problem and in different perspectives, the scientific or biomedical perspective, but also socioeconomical one. Then there is a blog explaining different challenges regarding bias and clinical practice. And then there is a final one regarding more the ethical and social challenges that we have for this problem. Then we have a second action, which is building best practices. Here, our objective is to identify sex and gender biases in the data acquisition processes. So this is a problem that affects mainly to data collectors, but also data curators and data users in the end. First, what we want to do is to create a repository of public biomedical databases and scientific publications. We are still working on that. And then to elaborate some guidelines of best practices for the research of AI applied to precision medicine. Our idea is to start with this because this is the main topic in our department, but the objective is also to work in collaboration with the rest of the departments of the Barcelona Supercomputing Center and try to find use cases for computer science, for earth sciences, where this dimension is also important and needs to be applied. So last year, in 2021, we participated in the Elixir Biohackathon Europe with a project called FairX, in which we aim to perform a quantitative and a qualitative analysis on large-scale public biomedical resources. We used, in this case, DPCAP and ETA. So this was a work performed during, let's say, less than a week in an hybrid mode. Some people were in presential in the biohackathon. Some of us were in remote. And so what we did was to collect all these, all the data that was available in these 2 databases. And we tried to see how these sex and gender variables were available in these datasets, and also how this information evolved during the year, so starting in 29 until 2021. We observed a main achievement in 2016, in which it was mandatory that this information was collected. The problem is that it was mandatory to fill the field, but not to always provide if it was a male or a female. You could also leave it with an unknown. So even if there is more awareness on this aspect and the importance of providing this kind of information, we see that there is still some work to do on that sense. And in relation to that, what we did was to build some recommendations, which is a very preliminary step, because as I said, it was a very short work, and now I will introduce it to you. But now what we want to do is to share this work with different kind of experts, especially people that comes from the field of data collection, in order to see how to make these recommendations more operational and to put them into practice in the daily life. This year, 2022, we will also participate in the Elixir Biohackathon. It will be in Paris. And what we want to do is to collaborate with Europe PMC. And in this case, we will take a repository of scientific publications that are available and try to identify through NLP text analysis in the whole paper, trying to see if they are taking into account the sex and gender dimension, and trying to see how this affects to the outcomes that are presented in the papers. So, 1 second. So as I said, this FAIR-X project and then the principles that we propose are based on the data sharing FAIR principles, which are data that needs to be findable, accessible, interoperable, and reusable. So we propose these 7 principles. I will explain it to you. One of them, it's something that has already been mentioned in the previous talks. I think it was Sabine that mentioned that there is sometimes, well, not sometimes, there is often this misconception about what is sex and what is gender. So sex, we are talking about the biological characteristic. Gender, it's more about the sociocultural behavior, the attitude, and the identity, the gender identity. What we found, and especially we found it in the EGA and DBGAP repositories, is that often when they are talking about the biological sex, the variable that they are taking is called gender. And this we can also find in scientific publications, in general audience dissemination, and it's something that we need to work on in order to avoid confusion and to improve the quality of the data that we are collecting and processing. Following that, we need some standards to improve the data management and the data quality in order to make them more interoperable between different institutions, and in the end, reusable, and promoting this open access to contribute to the FAIR principles. Also very important, it has been mentioned before, and also working aligned with these trustworthy AI guidelines of the European Commission, there is the privacy preservation principle. So we need scientific research that is aligned with ethical and regulatory frameworks here in Europe. They follow the European values. How to put it into practice? So now we have, for example, the GDPR that provides some mechanisms, such as, for example, the data protection impact assessment, in which you have different steps to ensure that the data is being tackled according to a risk management approach. There are anonymization techniques, but then there is also a field to explore using synthetic data or genomic data in order to avoid using or revealing personal data of the ones that are being collected. Then, very important, it's transparency. We need to promote open science and create easy-to-use quality indicators for dataset creators and curators. That means that before accessing to the whole dataset and processing it, being able to have some information that says if this data set will be useful for you or not, if it's the one I indicated for the kind of research that you want to do, and then if it's not, then you don't need to access it, you don't need to process it, and it will preserve some privacy, but also it will have a positive impact on the environment. And in the end, it will improve accountability. Then it's very important to talk about education, to create awareness, as I said at the beginning, and knowledge. So we need to include diversity in the dataset creation, but we also need to improve the research practice and the university curricula. This is something that Sabine also mentioned at the beginning. I will not go further on that. Then another principle is about social impact. Try to understand which are the effects of the precision medicine in underrepresented communities. Try to include all of them, not only in the data collection process, but also in the whole process. So in the design, in the validity of the systems, and find solutions that in the end will help building trust in the technology. And finally, engage the stakeholders. So create these participatory and multidisciplinary methods in every phase of the design that will have an active participation in the design, in the development and the validation, and especially in the use phase, in order to identify where there might be possible discriminations or flaws in the data collection, and in the end, improve the quality of research. And finally, one of the last things that we have done in the Bioinfo for Women program, and people that we are involved in this program, is to contribute with a report for the European Parliament. It's called Auditing the Quality of Datasets Used in Algorithmic Decision Making. We did this in collaboration with the Universidad del País Vasco. So in our site, we provided a technical review of the different ways that we can find biases in datasets, as David already explained. And the University of País Vasco, they did a review from the policy perspective. So in the end, we provided 5 policy options. The first one, and maybe the most important, is that we don't need to create new regulations for data sets. We just need to find the mismatches between the different regulatory tools and then work on that, and then have this precautionary approach in which we try to strengthen the bias mitigation from the data collection point. Data collection and data processing is maybe the most important step, because this is where we might find very important violations when we are, for example, labeling the data, and then this will be used for training. And if it's reused, then other third parties will keep reproducing the same biases. Then to promote a database certification, this goes with what we said before of having some kind of quality indicators. Strengthening the transparency rights of the AI system stakeholders, providing them an open communication of the capabilities, the limitations of the technology, and how all the process of the data collection and processing was done, and then to facilitate the implementation of the AI Act. And this is all on my side. I will now give the floor to Fateme. Let me stop sharing the screen.
Okay, just one thing before we started the hands-on session with Fateme, I would like to ask the participants if they have some questions about this second part of the workshop. So we presented what we do at Bioinfo for Women, especially in the research line, in our research line. So if you have some question, do not hesitate to write it down in the live Q&A, and we can answer this. I will like take advantage of this pause just to answer a question that was written down by Carlos Vega in the previous the previous part, and so it's about data. So probably it's like fitting this part better, and how to automatically analyze data. So he said essentially that. So tabular data sets do not convey the assumptions taken during data acquisition. For instance, it has been mentioned that taking samples during different moments of the menstrual period can affect the results, and this was mentioned by Sabine before. So he's asking, how do you recommend to convey these assumptions together with the data? As a description of the data sets, as a causal diagram, is there any automatized or actionable way to do it? So unfortunately, no. So basically, it's very difficult to infer assumptions that were there when the data is being collected directly from the data. It can be done, but you really need to probably, like, the way I would do that is to cross the data with other data. So to see if you can disentangle those assumptions. And this is like a big problem because sometimes you, for instance, you don't have, as I think I mentioned before, like sometimes you don't even realize that you have different subgroups of patients, so that you are analyzing people that belongs to a specific group against which a bias could emerge. And this is just because the data itself are not telling you, because there are not the variables inside. But there are, analytical approaches that allow you to understand this, especially the so-called proxy variables that are masking correlations and associations between external variables that can give you an hint if these kind of problems are there in the data. One example is, for instance, the address code. In the streets, the address code of individuals that is highly correlated with race. And so even if in your data set you don't have race, but maybe like it's a social study or something like that, and you have the address code, or maybe like it's in the records, in the medical records, and you can access this, you can use this information to see if there is a bias against race. So yeah, those are a bit, strategies, analytical strategies that you can apply in these kind of situations. So if you have other...
No, I just wanted to add, Davide, because we've talked about that there is a study in the United States about health insurance and how there was an imbalance between, let's say, white people and Black people. And once they deleted this kind of information, the improvement in insurance was almost reduced to zero. So in fact, it was, I think, 40 to 60% of white and dark people, because otherwise they were discriminating due to this kind of socioeconomic information.
Yeah. Thank you, Adia. So, well, if there are no other questions, let's move to the last part. Please remember to write the questions in the live Q&A, even if those are questions related to other parts of the workshop. So just drop the questions in the chat, and we will read it after Fatime's presentation. So okay, so Fatime, okay, yeah, thank you.
Okay. Hello, everyone. Good afternoon, and thank you for giving me this chance. Today, may I share my screen? Okay, today we are going, it's a hands-on session on the bias detection, and in this session I'm going to actually introduce some practical toolkits that we can use in our project for our data modeling, for the auditing, the bias, and the fairness. The main objective of these toolkits actually are to help facilitate the transmission or the transition of the fairness setting, and also to provide a common framework for the fairness researcher to share and evaluate algorithms. Here we can see a list of actually fairness toolkits, which are the most famous one. The first one is the AI Fairness 360-degree toolkit by the IBM. The next one is, as Davide introduced, is the Aguatis. It's a bias and fairness audit toolkit. And the next one is the Microsoft Fairlearn. It's a reduction approach. And the last one is the What If tool from the Google. So they are all coming from the big companies in the technology. And in this hands-on, actually, we are going to use the particular AI Fairness 360-degree degree. The package includes the comprehensive sets of the fairness metrics and the explanation for them, the details, and also the mitigation algorithm to apply to the models to mitigate the biases. So before jumping to the live demo, actually here we can see it's a general structure of the it's a general structure for the IBM AI Fairness, and it has been made of 3 stages. The first one is the training data, and after which we have the database. And after we trained our data set, we have the model, and at the end we have the prediction. In the framework, at each stage, we just test the data and we check for the biases. And after we check for the biases, we generate a report for the biases, and we try the algorithm for the mitigation ones. So here we will jump to the AI Fairness website, which we will demonstrate a demo here. As you can see, here is the website for the AI Fairness developed by the IBM. There are codes that in the future, if we want to apply it for our project, we have to use the code. But here we will use the demo part to see how it works. The first part of the demo is the data set. So we have to choose which data set we want to use. Here we have 3 data sets. The first one is the Compass one. The second is the German credit scoring. And the last one is the adult census income. So here in this session, we are going to use the Compass, the ProPublica recidivism. Actually, this data set is about that if a criminal has been known to the court. So based on a questionnaire they give to the criminal and based on some details about them, the algorithm will decide if the criminal is going to repeat the crime or no. Is it going to be reoffended or no? So the algorithm will decide it for them. And based on this data set, we have a protected attribute. We have 2 attributes, the sex and the race. The sex could be divided into male and female, as we can see here, we don't have only the sex, we don't have the gender. And for the race, it's the Caucasian, which is the white people, and the unprivileged group, which is the not Caucasian people. So the privilege here means that the outcome, the favorable outcome, is in their favors. And so here we check the data set and we push the next button. And here it will check for any biases in data set. So here we will see a set of metrics here. Actually, there are like 20 metrics that we can use for the projects, but based on the project, based on the data set, based on the which algorithm we are going to use in our model, and even the prediction we are going to use that specific metric. For here, based on that database, actually the IBM used these 5 metrics. The first one is the statistical parity difference, and as we can see here, once we click, it is computed as the difference of the rate of favorable outcomes received by the unprivileged group to the privileged group. So the ideal value, because we want we have the parity for the favorable outcome for the unprivileged and the privileged group, so the difference must be 0. But it's actually it's like never happened in the real world. So we have a fairness for this metric, which is between minus 0.1 to 0.1. But here, as we can see, our bias is minus 0.36. So it means that the male one, which is the unprivileged group, are getting like they don't have the disparity, they don't have the parity, and they are getting like more 30% more actually prediction than the female. So the next metric is the equal opportunity difference, and actually it's like the difference of the true positive rate between the unprivileged group and the privileged group. So it means that it's the difference of the true positive rate that our favor the true positive, which means that it means that we want this outcome and it is positive, yes. So here we can see it's not even the 0, because we want the equal opportunity for both. They will get the same true positive rate, and it's like 0.3. So the male or no, we can see they are getting less amount than the female. And the next one is the average odd difference. As we can see, it's the false positive rate. It's the difference of false positive rate and the true positive rate between the unprivileged and the privileged group. And the ideal value is 0. And again, we are getting like minus 0.35. And the last one is the disparate impact, which is the ratio of the rate of favorable outcome of the unprivileged group to the privileged group. So, which means that we should have the same amount for each one. So we get a ratio of 1, and here we are getting the ratio of something like 60%. So, and only 4 out of 5 metrics are biased, and we are only getting we are not getting bias for the tile index. And even for the other attribute, which is the race, we are getting the same. So we can see the black people, actually they are getting the bias, they are not having the equal opportunity, or they are not getting even the favorable outcome in a same manner. And then we go to the next stage after getting the bias report. So the important part is here, which is the practical part, that we need to apply some mitigation algorithm to the system. And actually for the algorithm, as we could see here, we could apply it in like the pre-process here, or we could apply it in process, or we could apply it at the post-process. So we could apply it in 3 stages based on our model. And how we decide which one we have to use it, it depends, actually it depends on our model, on the data set we are using, and the machine algorithm that we are going to use. So if, if for example, but it is recommended that we use it at the beginning if it is possible. But sometimes it is not possible. It is not possible that we just modify our data set. So we should keep it untouched, and then we go to the next stage, which is the in process. So we may modify our classifier, but if it is treated like that, it's treated, our data set and our model is treated like a black box, and we cannot touch them. So we have to go and modify our predictions. So based on the data set that we are having and its characteristic and the model that we are going to use, we have to decide which model is suitable for us. For example, if we can modify the data set, so we could use, for example, reweighting. Reweighting is once we cannot touch the data and we only change the weight of the data in the data set. So we could make the bias less, or we could optimize the pre-processing. In the optimized pre-processing, we could play with the features and the label in the training data, so we are able to modify them. But once we are not, for example, if we are not able to touch this part, the data part, we have to go to the next part. So we go to the classifier part. And if we could modify the classifier part, for example, we could use the adversarial debiasing. And if we are not allowed to do that, so we have to go in the last part in the post-processing. And in the post-processing, for example, if we use the reject option-based classification, we just we give the favorable outcome to the unprivileged group and unfavorable outcome to the privileged group, but in a confidence band around the decision boundary with the highest uncertainty. So for example, here we just go with because we have the ability to use from the beginning, we just go with the reweighting, and then we apply the reweighting algorithm to our data set and to our model, and to compare how we could decrease the amount of the bias. So here we could see that all the metrics that we applied in the first stage, now they have been improved. For the first one, we could see the amount of the bias, it has been decreased to minus 0.03, which is a very good number. So it means that now we have the favorable outcome for the privileged group, and the unprivileged group have like the same parity. And it happens to the other metrics, like the equal opportunity difference. So here, now it has gone to the favorable outcome is in the favor of even the unprivileged group, which are the men. And it happens for the other two metrics. And if we go for the next attribute, the race, we could see they have been improved in all metrics, which are, we could see here. Now it's in the favor of the Black people. And here is the bias report that the system generates for us, that we could see how the algorithm works, how at the first we just identify the biases, and then we move to apply some mitigation algorithm, and at the end we will compare these two biases reported, and we could see that we have decreased the amount of bias in our data set. But as we can see, this we only have here we have only 5 metrics, but we could increase our metrics, and we just could introduce the new metrics. So if we go to the home of the AI fairness, here we could see that there has the Python code and the R code that we could click on them and get the code, and we just modify it with our project, and the data set we have. And also here, the other toolkit that we can use is the Akutas. And it's actually, it has the same, that we could get the code and apply it, or even it has some interactive interface here. So we could just upload our data set here. And if the data set is in their format, because we should have the same in their format, if it is, they will generate some bias for us, and we could use it in the future. So, and for choosing the metric, because it's the critical part here, that how we could choose the metric, it could be a question. So there are like many decision tree that which metric we have to use, but this is one from the IBM and Akutas, and it's just for some metrics, not all the metrics. So for example, for our data set and algorithm, we are just going to check if we are going to check the parity, our parity for the representation, or is it based on the error of the system? And if we are going for the representation of the sample, then we are going to see if we are having the equal number of the people for each group, or no, we are having the proportional, because sometimes it's like impossible to have the same equal number of the people. So if we are going for the equal number, then we have to use the equal parity metric. And if we are going to have the proportional one, then we have to use the proportional parity. And if we go for the other branch, and if we are going for the disparity of the error, then we have to check, is it the intervention punitive or assistive? For the punitive, it's like the ProPublica data set that we use. If our decision, is it going to hurt people? Because if in the data set, the people was found committed to crime in the future, they will be reoffended. So it's they could hurt the people, especially, for example, the Black people. And if it is the punitive, we have to check, is it with a small percentage of the population? And if it is yes, then we have to use the false discovery rate parity. And if it isn't the no, then we have to use the false positive rate. And it is in the Other hand, if it is the assistive and it is going to help the individual, then is it going to be again on the small portion of the people? If it is, then we go with the false commission rate parity, and if it is no, then we will go with the false negative rate parity. So that could be a very good one that we can use to find out which one we have to use. And if you have any question.
Okay, thank you so much, Fateme. So yes, if you have any question, again, write them down in the live Q&A. So let's wait maybe 1 minute to... Okay, so it looks like there are no questions. And so yes, something that I would like to stress about this last part, as Fateme mentioned, is that those tools are often available as web pages, so like the ones that Fateme showed, and but also like Python packages, Python libraries that you can integrate in your code. So if you want to use these tools in a more programmatic way, you can also have have it as modules of Python, which is generally the programming language that is more often used, especially in bioinformatics and computational biology, but not only. So okay. Thank you, Fateme, for this practical demonstration. So, okay, looks like. Okay, yes, people is thanking for presenting the tools, which exactly which are useful, especially for practitioners in computational computational disciplines. This is definitely handy. Okay, I don't know. I would like to ask maybe Natalie and Datia if they have some questions, or they want to highlight some aspects or raise some discussion points. Otherwise, we can close the session.
Yeah.
So yeah.
No, I think the presentation was great in the way that have different point of view why we are working about sex and gender perspective. The presentation of Sabine give us the different point about how we can consider the sex a biological variable, and all the different thing that we need to consider that because as we talk, gender is social, but we have difference between the way that we think sometimes that the bionormal that women men, and actually we need to do a lot of things as we mentioned today in the educational way, how we work in data, how we analyze the concept that we define. And this is so important because as we mentioned today, as a researcher, we need to take into account the social impact of our research and how we can affect the underrepresented population. So I think it could be great that if you are interested in this topic, we can collaborate and try to find different collaboration to share also all the research that we are doing. As Ati explained, we are develop different papers right now, and also the Barcelona supercomputing is open to disseminate all these guidelines that we are developed for different departments. So yes, this is my conclusion, and we are open, and also as a research center to follow this line that is very important.
Okay, thank you, Natalie.
I just wanted to add that something that is very important from today's workshop is, because maybe you don't know, but we are a very multidisciplinary team. We come from different backgrounds and expertise, and this is something that I believe that we try to express today, because we can understand this challenge of the sex and gender dimension from different points of view. Okay, we saw but the biomedical point, but we also see that there are societal and ethical and even legal challenges, cultural challenges, and all of this is very important to integrate it in the research. I believe we need to integrate it even earlier in it when we are in educational phases, but this is a first step to try and to raise this awareness about the problem and try to understand it, and also think that this is not only a problem about biomedical research. This is something that we find in our daily lives in different aspects and different fields, and this is why I think it's important to start talking about that and showing some practical cases, because this has already happened traditionally in research and will keep happening. So we need to be aware of this in order to make better science. And that's it.
Thank you, Adia. So with these final words, I would like to conclude the session. So first of all, thanking again the ECCB organization, and thanking all of you for being here, for attending this workshop, for the questions and your interest, and also to the speakers. So Sabine Oertel Prigione for her keynote, and Nathalie, Atia, Fateme, and all Bio-info4Women for organizing this. So thank you so much, and well, let's be in touch. You can I put in the discussion forum the Bio-info4Women contact, so that you can so that we can stay in touch. Okay, you can write there. Thank you so much.
Thank you for the time. Bye bye.
Bye bye.